Mr. Chairman, it is indeed a privilege to have been asked to speak on the subject of globalization and health at the occasion of the annual meeting of the Center for Non-Traditional Security Studies in Singapore. Globalization refers to a multidimensional set of transformative processes which reach deeply into economic, political, cultural, technological, and ecological dimensions of contemporary social life. It is generally believed that globalization is a recent phenomenon. That is certainly not the case. In fact, the world started globalizing and integrating centuries ago when the wheel was discovered, when printing was invented, and when trade routes, voyages of discovery, and quests for territorial expansion opened new frontiers to a world that was ready to integrate. Such aspirations have taken their toll, a point the health globalization interface helps to highlight very clearly. The Black Death of 1347, which killed 1/3 of the European population, the 16th century inadvertent introduction of smallpox subsequent to the conquest of Aztec and Inca empires, and the global spread of influenza pandemic in the early 20th century are all cases in point. But perhaps it's not fair to begin with disease pandemics as an illustration of the impact of health globalization. In fact, interconnectivity and dependence have brought unprecedented benefits for improving health outcomes through development of global public goods, scientific discoveries, technological solutions, and coordinating mechanisms. Ladies and gentlemen, whilst it is true that the benefits of globalization outweigh its downsides, there are many caveats. It is important to appreciate that whilst globalization opens opportunities, there is need for appropriate institutional capacities to capitalize on those opportunities and to ensure that their benefits accrue equitably to populations. And it is precisely the need for such safeguards and institutional capacities which I would like to refer to as I discuss 6 points related to health's interface with globalization. The first point that I'd like to make is about health security. We are all aware that emerging and re-emerging infections, SARS earlier in the century and more recently outbreaks of avian influenza have profound implications. This realization was the driving force behind the global attention accorded to epidemiological security as an inherent feature of the health and human security paradigm, and it subsequently led to WHO's intergovernmental negotiations, which culminated in pronouncement of the International Health Regulations in 2007. But 4 years on, many questions have arisen with reference to country surveillance capacities. In fact, the considerable underreporting of H1N1 in 2009 has clearly pointed to the absence of well-functioning surveillance systems in some countries of Asia, and therefore failure on their part to fulfill commitments made under IHR. More recently, Mr. Chairman, with the outbreak of cholera in Haiti, the impact of lack of surveillance capabilities for a country's body politic, much beyond its macroeconomy, is becoming all the more evident. But then human travel is not the only consideration relevant to cross-border spread of diseases. In the 1990s, tiger mosquito, the potential vector of dengue fever, was introduced in the United States in a shipment of used rubber tires, a consideration which brings to the fore additional challenges for the implementation of international health regulations in countries with limited capacities. These challenges in health security are compounded by threats of bioterrorism in an increasingly complicated world, and they create imperatives for enhancing institutional competencies in the health sector which go beyond surveillance capabilities. Countries, ladies and gentlemen, now have to view health security not just as a feature of financial risk protection, which is primarily a domestic concern, but also in terms of epidemiological security, which is a broader global concern. My second point relates to globalization and the trade-health interface. In recent years, cross-border trade in health services has burgeoned due to a number of reasons. The 20th century information communication technology boom, which has created opportunities for business process outsourcing, business globalization, and WTO agreements on services and market mechanics are creating incentives both for the commercial presence of foreign service providers in host countries for the purpose of supplying health services as well as consumption of health services overseas. These mechanisms can add value to healthcare in a country in terms of fostering improvements in quality through the knock-on effect, but then they can also create inequities, which is why it is critical that the trade and health policies balance incentives for investments with appropriate safeguards. Another mode of trade in health services relates to migration of health professionals out of the country. Such movements, as we are all aware, can exacerbate health workforce shortages, as is currently being observed in many countries of Asia. The priority should clearly be to meet health workforce needs of a country through appropriate retention arrangements, as opposed to a focus on export on the premise that the latter generates foreign remittances. You are aware that global multilateral organizations such as WHO have negotiated intergovernmental frameworks in this area, but these are non-binding, and it is important for greater regional attention to this problem, which is becoming increasingly relevant for countries in Asia. On the same note, the TRIPS agreement is another trade health interface, and within that context, it is important to build country capacity to make use of flexibilities granted under the Doha Declaration on Public Health. Asian countries have pioneering work in this area, which can be important for knowledge sharing. Ladies and gentlemen, whilst we are discussing trade, let's not forget its potential downsides as well, which are clearly manifested in burgeoning of kidney transplant tourism and counterfeit medicines, which are increasingly plaguing several Asian countries. We need to deliberate on the need for Asian normative frameworks in view of these considerations. The third aspect of globalization in health, and perhaps the most important in relation to transformational processes in recent times, centers on communication technologies. Information communication technologies have revolutionized learning, continuing medical education, and information dissemination. They have made it possible to make quantum strides in improving connectivity in health information systems. In fact, the pervasiveness of mobile technology and burgeoning of mobile phone industry is leading to an emerging class of systems that blend mobile technology, health financing, and health service delivery, what might be called the interaction of mobile money and mobile health, or M-health and M-money. Initial successes have enabled upscaling in at least 80 countries, and the magnitude of market incentives indicates that progress could actually be meteoric in this area. But the real success of these will depend on the manner in which they are deployed to achieve the most important objective of achieving equity. And it is here that institutional commitment to uphold equity as a fundamental outcome will be critically important. My fourth point is about development assistance, which is increasingly becoming a foreign policy tool in a globalized world. In that process, it also brings much needed health resources to low-resource countries. There have been dramatic changes in the health sector official development assistance over the last 2 decades. In absolute terms, aggregate increases have been over 200%. The aid effectiveness movement, the Paris Declaration on Aid Effectiveness, and the Accra Agenda for Action are all a set of norms in a global architecture that call for harmonizing and aligning aid in support of particular strategies led by governments. However, we must also bring to bear results of OECD surveys which were conducted in 2006 and 2008 to monitor the implementation of the Paris Principles. These have consistently pointed to systemic weaknesses in domestic governance as the key impediment to reaping the benefits of aid. And that is a point that I have consistently been making all along this presentation. There's another aspect of development assistance which centers on the creation of global health initiatives and global health partnerships, or global public-private partnerships. A plethora of arrangements already exist which are primarily focused on infectious disease control, product development, improving access, global coordination, and several kinds of interventions to strengthen services. As a result, many diseases of poverty have been eradicated from the face of this planet. Organizations such as the Global Fund and Gavi have made much needed health resources available to poor countries. Progress in HIV and AIDS in Africa would not have been possible without investments by PEPFAR, which have taken development assistance to a completely different level. My fifth point is about a dimension of globalization which relates to lifestyle choices. Globally, 4 of the top 6 risk factors for death, high blood pressure, high blood glucose, overweight and obesity, and high cholesterol level are all related directly to nutrition and sedentary lifestyles. They account for 27.9% of all deaths. The public health approach to risks and diseases which fall within the rubric of these chronic diseases is interlinked with the role of the private sector, multinational corporations, which can play an important role through reshaping the industry to introduce or diversify towards healthier products, making healthy options available and affordable, and alter marketing practices. There is now a movement towards self-regulation amongst the major food and industry players, and it is important to consolidate and mainstream that momentum as we head for a global response to NCDs during the UNGAS NCDs session planned for September 2, 2011. Lastly, but most importantly, ladies and gentlemen, I would like to refer to an aspect of globalization which relates to norms, standards, and regulations. I would like to leave you with some questions with regard to the manner in which they may hold relevance for Asia. In today's world, goalposts such as the Millennium Development Goals, health for all, and universal coverage unite us in a common set of principles and vision for the future. We need to explore if there is need for an Asian vision. Today, internationally binding regulations such as the Framework Convention for Tobacco Control, international health regulations, and WTO agreements form a set of global agreements which have become a reference point for institutional action in countries. On the one hand, Asian countries are taking a lead in fully implementing them and are taking advantages of flexibility. But on the other hand, Asian countries have capacity constraints. Is there a need for mechanisms to enable sharing of experiences regionally and developing channels for building capacity? I leave you with that question. Today, ladies and gentlemen, global norms, standards, measures, and instruments developed by multilateral agencies mandated in that role unite the 3 worlds in a sense of common purpose. But power is unevenly distributed between countries and makes some countries dependent on frameworks and conditions set by others. Is there a need to view this within the Asian context? I leave this thought with you. Is there a need, ladies and gentlemen, for regional capacity building to examine the health risks of an unregulated global economic system? Is there a need, ladies and gentlemen, for greater regional emphasis as global health gets traction as a foreign policy issue and the term global health diplomacy gets coined? And at the heart of this, is there an Asian imperative which takes cognizance of contemporary globalization and structures a system with a view to upholding health equity? In my opinion, regional think tanks such as the Center for Non-Traditional Security Studies are ideally positioned to convene experts to deliberate on these questions. I thank you, Chair.